Good afternoon, and thank you for attending this CumbriaMed Research Webinar. I'm Professor Jonathan Weber, and together with Professor Sophie Day, we run the Pears Cumbria School of Medicine Research Hub, which is the host of these webinars. So the aim of the webinars is to bring and showcase the research of the Pears Cumbria School of Medicine with local NHS partners and the University of Cumbria, and really demonstrate the role of research in the partnership and the potential impact into care for patients, the NHS in Cumbria. We're enormously pleased today in this webinar to be looking at the issue of health inequalities, and with two terrific speakers, both representing major initiatives through the National Institute of Health Research, the NHS Research Funder. The first one on maternal disparities in health, and the second on mental health inequalities. So without further ado, it's a great pleasure to introduce Professor Judith Rankin. Judith is Professor of Maternal and Child Health at the University of Newcastle and is the co-lead of this new NIHR Challenge in Maternity Disparities Consortium. This is a very major grant, which you're going to hear about, addressing this area of immense national importance. So, Judith, I encourage you to show us your slides and give us your presentation. Thank you.
Thank you very much. So I'm just sharing now. Obviously, when I'm sharing, I can't see anyone. So if you could just let me know that those are
the slides
now,
are up.
That's perfect. And if there are any issues as I move through my talks with the slides moving on, please do let me know. So thank you very much, Professor Weber, for the introduction. As said, I'm Judith Rankin, and I'm Professor of Maternal and Child Health in the Population Health Sciences Institute at Newcastle University. I'm also an NIHR, a National Institute of Health and Care Research Senior Investigator, and for the purposes of today, obviously, I'm going to be talking to you about being co-lead for research and capacity development for the new NIHR Maternity Disparities Consortium. So what my plan for today is really to tell you what is this. You may have already heard the words Maternity Disparities Consortium, but don't really know what it is or what we're planning to do, and then where we are up to in terms of its gestation. What a good word to use when you're talking about maternity disparities. But before that, I want to just give you some of the context that has really led to the establishment of this consortium. So we know that Black women are 3 times more likely to die from childbirth than white women, and the proportion is 2 times more likely to die for Asian women. And we also know that women who live in the most deprived areas are 2 times more likely to die than those living in the least deprived areas. So these are really stark statistics to start this presentation with. And these are statistics that unfortunately have been pervasive and have not been amenable to change over a number of years now. And I've just included these 2 graphs to illustrate this point further and to illustrate the point about these disparities in terms of maternal mortality rates have now been going on for quite some time. So the graph to my left is around maternal mortality rates by different ethnic groups, and the dark blue line at the top represents maternity mortality rates within Black women, and if you compare that to the lower blue line, which is the maternity mortality rates for white women. The other graph is about maternity mortality rates for women from different levels of socioeconomic deprivation in England. And again, the dark blue line at the top is for those living in the most deprived areas compared to the blue line at the bottom for those living in the least deprived areas. These disparities are not just among women and the outcomes of pregnancy, they also impact on the outcomes of pregnancy. So here we're talking very specifically about stillbirth and neonatal mortality rates. And again, you can see the stark differences in both stillbirth and neonatal death rates. So for stillbirths, the rate per 1,000 total births is 7.52. For Black women's and 3.30 for white women's children. And in terms of neonatal deaths, the rates are 2.94 compared to 1.68. So these maternity disparities is not only in terms of maternal outcomes, but also in terms of pregnancy outcomes. And this is a further example of disparities, and this time looking at pregnancy loss. So we do know that there are persistent inequalities in loss for Black and Asian babies and those babies born in deprived areas. And a recent report undertaken by SANS, that's the Stillbirth and Neonatal Death Charity, has calculated that if between 2017 and 2021, the stillbirth and neonatal birth rates have been the same for Black and Asian babies as they were for white babies, 1,704 babies would have survived. I've talked up to now very specifically about the disparities among outcomes, pregnancy outcomes, but it's not just about outcomes. The 5 times more Black maternity experience report presents very stark data about the experience of maternity services as reported by Black women. I'm not going to go through all of these statistics, but just to highlight a couple. So 45% of women raised concerns during labour or birth, and of these, 49% felt their concerns were not properly addressed. 23% of Black women did not receive the pain relief they requested, and 40% of these women were given no explanation for that. So it's against this really depressing background and the context that I've provided that the then Health and Social Care Secretary, Victoria Atkins, launched at the Women's Health Summit in January 2024, announced the launch of the first ever research challenge worth 50 million, which was to tackle maternity disparities. And this became the NIHR Challenge Maternity Disparities Consortium. The approach that these challenges will take is based on the core 20+5 approach, which, as many of you will be familiar with, but this is designed to support integrated care systems to drive targeted action in healthcare inequalities. So the core 20 represents the most deprived 20% of the national population as identified by the Index of Multiple Deprivation. The plus are the integrated care system's chosen population groups that they think are experiencing, based on their data, poorer than average health access, experience and outcomes. And the 5 relates to the key clinical areas of health inequalities. As I've mentioned, maternity is the first of the NIHR challenge calls, but we've also recently had the cardiovascular challenge call, which has now been launched as well, and there will be further calls. So what was the purpose of this challenge call? What was the NIHR really were trying to do with this investment? And it's really around 4 key areas: to bring together a diverse consortium of organisations, funding research and capacity building, and I'll return to that later; to increase the evidence base to drive action to reduce maternity inequalities and lead to better outcomes, both for women and for their babies; develop the next generation of researchers to address maternity inequalities, and to facilitate a multidisciplinary whole systems approach to addressing uncertainties across research, innovation, and implementation. So really just want to emphasize that there are 3 dimensions of inequity that the Maternity Disparities Consortium is addressing: outcome of pregnancy, access to maternity services, and experience of that access to services. So the call was put out in May 2024, and applicants were asked to put together collaborations which were then applied to be part of the consortium. And 9 of those collaborations, as illustrated here, excuse me, were successful. And I think the key thing to point out here is that this consortium is UK-wide, so we have representatives from each of the devolved nation. And of those that were successful in becoming part of the consortium, the collaborations included 18 universities, companies, councils, NHS trusts, charities, local government, clinical commissioning groups, etc. And I'm really just emphasising that the point that the NIHR were really keen to do was that different organisations were coming into the consortium and being part of its research. So one of the first things that was undertaken was the appointment of the co-leads. So my colleague, Professor Jyoti Singh Shandan, is co-lead for research for the consortium, and I was appointed as co-lead for research and capacity development. And then in terms of what we've been doing over the last sort of 12 to 15 months, the first thing we did at the end of 2024 was actually to take those stage 1 applications and do a thematic analysis in terms of understanding the key strengths that the different collaborations were bringing into the consortium, their research priorities, training needs, etc. There was so much work and effort put into those stage 1 applications, we didn't want to not use that to inform our direction of travel as in the consortium. Our phase 2 really was all about partnership building, so trying to strengthen those partnerships that had already been made within the collaboration agreements, but also across them and within the consortium, and really identifying what opportunities there were in terms of capacity building and any gaps in terms of those organisations that we had within the consortium. We all came together for the first time as a consortium at the end of 2024, and that also saw the establishment of our executive group. Going into 2025, we undertook at pace a research prioritisation exercise. And this, as the name suggests, was really trying to work out what were the priority areas that we wanted to develop in terms of our themes, through which our research would be delivered. Having done that, and that was a series of iterations, we then worked towards our business plan and appointed leads for the work streams and themes, and I'll come on to tell you a little bit more detail about the themes and work streams. And we're now at a situation, so since the business plan was approved last July, the themes and the work streams are working to develop their research plans, and currently those are with the NIHR for review and for external review before we move to contracting. So that was a whistle-stop tour of what our activity has been as part of the consortium over the last 15 months. In terms of the themes that's through which we're going to deliver our research, we have 5 themes, and again, very quickly, I'll take you through what those 5 themes are. So the first one is around access and experience and communication. So this theme is very much around ensuring that maternity services are welcoming, easy to navigate, and culturally safe. The second theme is around perinatal mental health and psychosocial well-being. And this theme aims to prevent, identify and address perinatal mental illness using integrated and community-informed models of support. Our preconception and interpregnancy health theme plans to embed care and support before and between pregnancies to improve health trajectories and reduce risks. The maternal and neonatal health risks prevention and recovery theme will target modifiable drivers of maternal morbidity and neonatal complications, and this is particularly within underserved groups. And finally, our 5th theme is intersectionality and tackling systemic racism or discrimination, which plans to develop and evaluate anti-racist rights-based interventions within its work. I also mentioned that we had 2 cross-cutting work streams. So again, I'll just give you a little bit of detail about those 2 work streams. So our first one is community engagement and co-production. And this work stream will work to ensure that all activities are grounded in lived experience with service users as equal partners. And our digital data monitoring, evaluation and implementation science work stream really does provide the analytical and methodological backbone for the whole programme. Okay, I also mentioned at the beginning that this call was not just about research and doing research in a different way, but it's also about developing the next generation of researchers. So I'm going to say a little bit about our capacity development programme. So 10 million of the 50 million has been ring-fenced for capacity development, and really what the NIHR will expect from that is we will deliver a step change in the way we approach capacity development, which in turn will lead to a step change in the health of both women and their babies, and also support those who are planning and commissioning, managing, delivering and using services to reduce disparities in outcomes. So again, we went through a process of looking at what the stage 1 applications had put forward in terms of capacity development. We undertook a survey across the consortium about what the gaps were and how could we fill these in terms of capacity development, and then working very closely with the NIHR Academy, what their priorities were in this space as well. So we've come up with a number of different types of capacity development opportunities that we'll be launching over the next 4.5 years. Many of them you would expect. They are the type of things that you would expect to see within a consortium. What we have tried to do is where there is something that the NIHR already offers, that we go beyond what that offer is. And we've also included maybe some more novel aspects to this. For example, our community capacity development opportunity really works closely with those working to support maternity, but in the community setting, to develop capacity or to have opportunities to lead small projects, etc. So hopefully there may be some opportunities there that you're interested in. Okay, so obviously setting up excuse me, something like a consortium has both its opportunities and challenges. So I'm just going to talk a little bit now about those very briefly before we draw this to a close. So being the first of the NIHR challenge calls, obviously we all were coming to this new, and we didn't really know what the expectations were, and we've been working together through that. So there was a lot of scratching of the heads at the beginning to try and work out exactly what it was we were trying to deliver. We've been referred to as the vanguard, etc. And I suppose we have been laying the trail for these challenges, but there have been some question marks in the way in terms of being very clear about what it is we're trying to achieve. And there's also been, there was no roadmap for this. There was nothing we could go to before. So in terms of process, we have been trying to work through what is the most efficient and effective process for these challenge calls. The third one in terms of challenges is around bringing people together who haven't worked together before and who haven't had a huge amount of time to get to know each other. Has caused some challenges along the way, but I'll come back to that in a moment. And then the last one has been around time. We are trying to work at pace. There's a lot of expectation around these challenge calls and the consortium, and we are having to work at pace to deliver on that, which has time always has its challenges. But of course, there are huge opportunities within this Maternity Disparities Consortium. One of the first things that's been a real opportunity is the fact that maternity and maternity disparities is well and truly on the NIHR agenda now. So while we will be tasked to deliver particular work programs within the consortium, maternity disparities is a priority across all of NIHR. So there'll be opportunities through funding, through other programs within the NIHR in terms of maternity disparities research. I said that bringing people together for the first time was a challenge and having to work together at pace, but that's also been a huge opportunity in terms of the way that we're all been thinking, being exposed to people from different expertise, different ways of doing things has been hugely beneficial as we've been working through what the research programs will cover. Having that ring fence money, that investment in training, again, I suppose I'm going to say this, but I think that is a huge opportunity in terms of training and capacity development within maternity disparities and setting up the workforce and the research skills for the future leaders in this space. And of course, a huge opportunity to actually move the dial on in terms of those really awful statistics I showed you at the beginning. So in terms of pregnancy outcome, access to services, and also experience of those services. Okay, so just finally, this NIHR challenge call really is tasking researchers and policymakers to find new ways to tackle maternity disparities. What we've been doing up to now has not been working, so we've really got to think about this in a different way. And that's through undertaking large-scale, co-developed, integrated, transformative projects, which we hope will drive measurable improvements through each of the themes and supported by the work streams. And we really are hoping that we, through this consortium, will improve outcomes for women and babies, improve access to care and experience of that care. I'll end there. Thank you very much for listening, and I'll hand back. Thank you.
Judith, thank you so much for that. What an ambitious program and how exciting. And I do encourage anyone with any questions to start to put them in the Q&A now. And while you're doing that, I'm going to introduce my colleague, Professor Joy Duxbury from the University of Cumbria. Joy is Professor of Mental Health and Director of Research still for the Institute of Health, University of Cumbria. She's a mental health nurse by background and a clinical academic with really a lifetime of research in improving mental health with a particular attention and focus on those underserved and under-resourced settings. So Joy, without further ado, over to you.
Thank you, Jonathan. I'll just share my screen if that's okay and get that sorted and hope that I don't share my bank accounts with everybody, which is what I normally do. Okay. Right. Well, thank you for inviting me, and I'm delighted to talk about this subject, which I'm extremely passionate about, inequalities and mental health. I think this is going to be very focused on Cumbria specifically and some of the work that we're doing at the University of Cumbria and with partners. I think the first thing to say, interestingly, is, and I speak as somebody that actually has only been living and working in Cumbria for 2 years now, and really only came up to Cumbria, I guess, as a tourist, so to speak. And I think therein lies some of the problem. It's a real tale of two cities, I think, the county of Cumbria, in that many people associate Cumbria with the beautiful national park and don't see beyond the bigger picture in terms of some of the inequalities outside of the national park. I thought just to give some context here around the geography of Cumbria. Of course, as I say, we've got the Lake District itself, and then we have all the various aspects of it around that. And again, I'm not quite sure who's actually on the call and how familiar you are with Cumbria. I suspect many of you are, possibly even more so than me, but we are served by 2 councils, Cumberland and Westmoreland and Furness. The population is also served by 2 mental health trusts, CMTW in Lancashire and South Cumbria. And we work very closely with what's called 2 applied research collaboratives, which are funded by the NIHR, which I'll say a little bit more about towards the end. So that's North East and North Cumbria Research Collaborative, and also the Northwest Coastal Collaborative. So there are a significant number of disparities generally across Cumbria when you look at the statistics and when you read a number of reports that have been done on Cumbria itself. There are a number of disadvantages there is a 16-year difference in male life expectancy across the Cumbria Council. Now, there are pockets of this in certain aspects, and I will go into this in a bit more detail. 1 in 4 people are aged over 65, so we have an ageing population. People come up here to retire. 2/3 of people live in coastal towns. There are concentrations of deprivation in these areas, coastal and rural areas. Many geographically marginalised communities exist for a whole host of reasons that we can talk about. And in terms of employment, it's often low paid and insecure and unstable, whilst the cost of housing and daily living are high. With regards to the prevalence of mental health concerns, and I'll show you some figures around this, there are high levels in the north of England, so not just specifically Cumbria, but in the north of England generally, there are higher levels of mental health disparities, particularly concentrated in areas of high social deprivation. And over 1 in 5 adults in Carlisle, for example, are diagnosed with depression, and that's the 4th highest rate in England. The suicide rate is twice the national figure in some deprived areas of Cumbria. That's not right across Cumbria, but certainly in deprived areas. And emergency admissions for intentional self-harm are almost double in Carlisle and Barrow-in-Furness than they are in England more generally. There are high mortality rates for something called deaths of despair, which largely relate to deaths as a result of alcohol or drug abuse, or by suicide, or indeed by self-harm. And the rates for children and young people are similar in terms of mental health to the national picture, albeit admissions for self-harm are higher in our region than compared nationally. That just gives you a bigger picture in terms of mental health concerns. I'm only going to focus on certain aspects today, folks, largely because, I don't have time to go into the raft of the mental health portfolio, population or conditions that one might see. So I'm focusing on depression and things related to deaths by despair, as I mentioned earlier. So in terms of depression, and you remember at the start I said that we're served by 2 councils, Cumberland, Westmoreland and Furness. So in England, the rate for 2024 to 25 was 14.3%. And you can see straight off that in Cumberland in particular, we are higher than the national picture in terms of depression in Cumbria. It's interesting because Judith said in her presentation, this, paints a stark picture, I guess. And it also shows us, I think, for our region, that there is a real need, a mental health demand. And in fact, CNTW, one of the trusts I mentioned, there'd been a stark rise in the need for services, I think of something like 50% over the last few years. Across the whole of England, the number of people being recorded, and again, this is being recorded by GPs, of having a diagnosis of depression has nearly doubled in 10 years. Naturally, when you start looking at figures that are, is this a case of we just have better recording, or is this a really important feature of the mental health status, I guess, of people across the country, but also in Cumbria? And this just gives you a bit of an idea of how you can see that, particularly in Cumberland, so that you see the black figure at the bottom is a steady rise of depression recorded on GP registers from 2013 to more recently. And Cumberland, as you can see, is right at the top of that graph there. And this is just a bit more of a breakdown in relation to the prevalence of depression by regions within Cumbria. And again, I've highlighted in red there where you can see the higher rates, particularly in comparison to the national picture in England. So Carlisle, Morecambe and Lonsdale, and Whitehaven and Workington in particular. The northwest we have higher rates generally anyway, but in Cumbria, even more stark contrasts of depression. So I mentioned deaths due to despair. An estimated 46,200 people have lost their lives due to deaths of despair nationally. Rates were higher in the north and in coastal areas, and alcohol-specific deaths were the largest contributors to these, accounting for 1.4 percentage of all deaths. That was across England. Deaths of despair in England are spatially patterned, with northern regions, as I've alluded to, experience a much higher burden of mortality from these avoidable causes. And living in the north, I think factors that are influential here are unemployment, white British ethnicity, living alone, economic inactivity, employment rates in elementary occupations, and they have been significantly associated with the elevated deaths due to despair risk, as reported in this paper by Camacho et al. And this is just a pictorial example of this. You can see the northwest there up to the top. So the orange and amber colours are where there is a particularly high level around the country, but you can see how that affects us above the northwest, which is where we are. And you can again see how that's coastally related. So that's my suicide in Cumbria. Always very sad to talk about these things, but I think it's really important that we do, and that we really hope that we can start addressing these matters as to why the suicide rates might be high in certain areas. You can see there again that Cumberland in particularly, we have higher rates than we do in England, particularly in relation to the male population, but also much higher rates with females also. Cumberland specifically is a feature of this. I wanted to show you these two pictures because, again, it paints an interesting picture here. So what this shows is where the common mental health conditions are most prevalent. So the darker purple is where mental health conditions are most prevalent. And again, you can see those matters related to the northwest and northeast and North Cumbria at the top there. But when you look at the second picture, which is where you have the orange and the amber features, that relates to how much research activity has been going on in those regions. And so the paler orange colours show you where there's less research activity. So what we have here is we have a very high rate and a higher prevalence of mental health concerns, but we have a much lower evidence of people being recruited to mental health studies, which again is a huge concern, and we are looking to address that. So in terms of the University of Cumbria and local need, until relatively recently, there's been a limited mental health research portfolio at the University of Cumbria. As I said to you at the start, I've been at the university now for 2 years, with a whole background and portfolio of research in mental health. That there are some really great colleagues working at the University of Cumbria who've been here for some time. We've been doing pockets of research, but more so in isolation. And subsequently, there's been limited capacity for those researchers to undertake specifically targeted mental health research without the support that they've needed. Developing relationships with agency, etc., in mental health, despite mental health need, has been really important for us. But there's been poor research recruitment, as I alluded to before in the picture. The University of Cumbria is really committed to growing research capacity and capability and identity in applied mental health research. And I'll give you some examples of that shortly. Recent work with community groups and people with lived experience highlights potential emerging areas. I have been blown away by the first partnership working, I think, across Cumbria, having arrived. People are desperate to work with the university and see the University of Cumbria as their university, and they really want us to support them in really addressing some of these inequalities through research. And we have new relationships with a number of significant partners, I guess. Obviously, the reason why we're having these webinars, and Jonathan has introduced us and has been central and key to this as a Sophie, is because we now have the Pers Cumbria School of Medicine, which is amazing and will provide us with all sorts of opportunities. We work very closely with Cumberland Council's Health Determinants Research Collaborative that's funded by the NIHR. We have the I mentioned earlier, we have the Northeast North Cumbria ARC, and we are now partners with Northwest ARC as well, which will provide a raft of opportunities for research across not only our region, but with partner universities around the North East and North Cumbria and South as well. And I'm going to talk to you about something called the Mental Health Leaders Award, which is really providing us with an exciting opportunity for Cumbria. So the Mental Health Leaders Award, which is funded by the National Institute of Health Research, we have just been awarded that. It's for £2.5 million over the next 3.5 years to address this very issue of inequalities in mental health research across Cumbria. There are 4 research themes that we have identified through already having conducted some consultation work with Cumbrian residents and with Cumbrian partners. And they are challenges associated with crisis in the community, the specific needs of children and young people in Cumbria, the complex needs of people with neurodiverse challenges, and then the use of green and blue space in order to really start addressing some of these issues. Just going to show you a very brief video by Alexis Quinn to just tell you a little bit more about the Mental Health Leaders Award. Alexis is what's called our PPI lead, our Patient and Public Involvement lead for the Mental Health Leaders Award. And she can tell you in a much more articulate way than me what we are trying to achieve with the Mental Health Leaders Award.
Hello, my name's Alexis Quinn. I'm the manager of the Restraint Reduction Network, and most importantly, I'm the lived experience lead for co-production on this new Mental Health Leaders Award at the University of Cumbria. I'm pleased to be included to think about what this project means, not just for the region of Cumbria, but for people from underserved communities. My involvement in this work is deeply personal. I'm an autistic woman, a mother and a teacher. But for 3.5 years, I was a patient, inappropriately detained in a mental health system. I was misdiagnosed many times before anyone recognised that I was autistic. During that time, I was restrained, secluded and forced medication. Not because I was unwell, but because the system, it just wasn't equipped to understand or support my needs. It saw my autistic responses to the chaotic, overwhelming environment as a risk that needed to be controlled. What I experienced, it wasn't care. Actually, at times, certainly when I was in long-term segregation, it felt quite torturous. So I know what it's like, I guess, to have your voice silenced, to be treated as a problem, to be managed, rather than, I guess, as feeling as a person, right, that needs to be understood. I had to escape the country to finally get the drugs out of my system and reclaim my life. And for me, that's why this project is so critical. My role as the lead for patient and public involvement and co-creation is to make sure that people's needs are met in a timely way and that they are met with care and compassion, ideally proactively. For too long, research has been something that's done to people, and what we plan to do is to do it with people. This project has baked lived experience to its very core. It's in the overarching strategy, it's in the advisory groups, it's in every research theme. So whether we're exploring gaps in services from minoritised communities, thinking about the challenges of getting crisis care in remote areas right, or the needs of our young people, the people who have lived it will be our experts. They will help us ask the right questions. And most importantly, they will help us co-design the right solutions. So what's my hopes for this award? Well, first, I hope we create research that makes a real tangible difference. This is not about writing academic papers that sit on a shelf. It's about developing practical solutions that improve and save lives, improve lives in Cumbria, a region that's been significantly underserved by mental health research. Second, I hope we build a new culture of research, one where researchers, clinicians and people with lived experience are equal partners. We'll be training our teams in co-production, cultural competency and inclusive methods that make sure this partnership is genuine and effective. And finally, my greatest hope is that we can prevent the kind of trauma I and so many others have endured. It's only when we really listen to communities that we can create services that are compassionate, that understand different minoritised perspectives, and that offer the right support at the right time. Preventing crisis instead of just reacting to it. So, thank you, Joy Duxbury, for all of her leadership. We've been clear together and with all the other partners that this 2.5 million investment is a turning point for mental health in Cumbria, and it's with Joy's leadership and that of our partners that we can have this chance to do things differently, right, to get things right. And I'm incredibly proud to play a small part in that. And I invite you, as people that are in the communities in Cumbria, to join this vital work. Thank you.
Thanks, folks, and thanks, Alexis. Just to say that we are recruiting to the Patient and Public Involvement Advisory Group as we speak, with Alexis driving that work. I've only got 2 more slides now, folks, because I know it's really important that we get questions now. Just really that the objectives of the Mental Health Leaders Award is to build capability and capacity across Cumbria, strengthen community engagement so that we really get an understanding of the needs of the community, really embed and upskill in terms of methodologies across the University of Cumbria and with partners, and basically invest in mental health research. So really just summary to give you an overview, I guess, of what I've said so far. We know that there is spatial patterning and significant problems with that in relation to socio-economic deprivation across Cumbria. Regional disparities underscore many of those aspects that need to be addressed through policy planning and geographical tailoring. Concerns have been raised that funding allocation is not being distributed according to need. And of course, now that we have things like the Mental Health Leaders Award, I think that the tide is turning and we are beginning to see an investment in areas like Cumbria. The English policy of devolution, transfer of decision making, is going to be central to this, and tailoring solutions that are locally delivered, strengthening community resilience, and making sure it's place-based and public health approach is central to much of this. Community engagement collaboration is essential, and fundamentally further research is needed to really start addressing some of the structural inequalities that we are seeing in places like Cumbria, and it aligns with some of the priorities for the NHS 10-year plan, not least of which around prevention, public health, but also working with neighbourhoods and communities. And our work with the partners that I've mentioned to date, and particularly the infrastructures that we have currently, is central to all of that. So thank you for listening.
Can I thank both speakers very much for their excellent presentations on these critical areas. Can I thank all of the audience who attended? Thank you.